Hey, welcome back to the Deep Dive.
Great to be here.
Today, we're tackling a topic that's just incredibly important, especially in clinical practice, HIV in pregnancy.
Mm-hmm.
We've got a set of pretty detailed revision notes here, and our plan, really, is to unpack all this dense info, make it clear, make it memorable, and really high yield for you.
Yeah.
Whether you're hitting the books for an exam, prepping for a clinical setting, or, just curious, we're going to pull out the absolute must-knows
Yeah.
and try to make them stick.
Absolutely. Medical notes, they can be so thorough, but sometimes you lose the main points, right?
Yeah.
Identifying those critical facts, the connections, that's the challenge.
Right.
So using these notes as our guide, we can sort of highlight the core stuff, understanding the condition, why certain things are done, and what the key outcomes actually are. Cutting through the noise, basically.
Okay, let's dive in then. Our source material kicks off, logically, with the absolute basics. What is HIV, fundamentally? And when we talk about it in pregnancy, what's the sort of main goal highlighted in these notes?
Okay, so HIV, at its core, it's a viral infection. The notes point out its main target is the immune system, specifically those vital CD4 cells. And if the virus isn't kept in check, it gradually damages the immune system, which down the line can lead to AIDS-acquired immunodeficiency syndrome.
Right.
Now, HIV in pregnancy, that just means the infection is there in someone who's pregnant. Pretty straightforward. But the notes make the objective crystal clear right away. The focus of treatment and management is all about minimizing harm to both the pregnant person and the fetus, and, crucially, dramatically lowering the risk of passing the virus to the baby.
That transmission piece seems central.
It really is. That potential vertical transmission mother to child, that's the core problem these notes want you to understand how to manage.
Got it. So you're managing two patients, in a way, and preventing that transmission is paramount, which leads us right to the how. How does HIV actually spread between people generally, based on these notes? And then specifically for us today, how does it pass from mother to child?
So the notes cover the main routes for HIV transmission in general. Unprotected sexual intercourse, that's a major one.
Okay.
And sharing contaminated needles or syringes, that's another big pathway.
Right.
Then when you narrow it down to mother-to-child transmission, or vertical transmission as it's called, the notes specify 3 key points it can happen during the pregnancy itself, during labor and delivery, or afterwards through breastfeeding. Knowing these specific moments is, well, fundamental because all our prevention tactics are aimed at blocking the virus at these stages.
Okay, that makes sense. Block the pathways.
Yeah.
Now, here's where it gets, really practical and interesting, I think. The notes go into what increases the risk of getting HIV, but maybe more importantly, what drastically reduces the risk of passing it to the baby. Let's start with the risk factors for acquiring HIV during pregnancy itself. What do the notes say?
Right. So the notes list things that make it more likely for a pregnant person to get infected with HIV. Things like having unprotected sex, especially if the partner is HIV positive, other kinds of high-risk sexual behaviors, using needles or syringes that aren't clean, and also having other existing infections like other STIs or even a previous HIV infection. Sometimes these can make transmission a bit easier.
Okay, so those are the risks for acquiring it. Now, the flip side, and this sounds like where the good news is, what factors really cut down that mother-to-child transmission risk? You mentioned it was dramatic.
It really is. The notes highlight this incredible reduction. Without any intervention, the risk could be anywhere from, say, 25 to 30%.
Wow.
But with effective management, it can drop to as low as about 2%. It's a massive difference.
That is huge. From potentially 1 in 3 or 4 down to 1 in 50. It really shows how effective these interventions are. So what are they, these key factors? The notes frame them almost like pillars,
Pillars is a great way to think about it. The notes point to 4 fundamental areas for preventing vertical transmission. You could definitely make a mnemonic out of this for revision.
Good.
First, and probably most important, is maternal antiretroviral therapy, RT. This is the medication the mother takes to suppress the virus in her own system.
Right. Less virus, less risk.
Exactly. If the virus isn't actively replicating in the mother, it's much, much harder for it to be passed on.
Okay. Pillar 1, maternal RT. What's next?
Second is the mode of delivery. The notes mention that sometimes, depending on the situation, particularly the mother's viral load near delivery, a cesarean section might be the safer option.
Why is that?
It potentially reduces the baby's exposure to the mother's blood and bodily fluids during the birth process compared to a vaginal delivery.
Okay. Mode of delivery, pillar 2.
Third is neonatal antiretroviral therapy. So this is medicine given to the baby itself soon after birth.
Like a post-exposure prophylaxis.
Sort of, yeah. Think of it as an extra layer of protection, just in case any virus managed to get through during pregnancy or birth. It's a preventative shield for the baby.
Makes sense. Neonatal RT, pillar 3. And the last one.
And the fourth pillar is infant feeding. The notes are quite specific here, particularly for settings like the UK. They advise against breastfeeding because HIV can be transmitted via breast milk.
Right.
So formula feeding is recommended instead to eliminate that route of transmission.
Okay, so the 4 pillars. Maternal ART, mode of delivery choice, neonatal ART, and infant feeding method, no breastfeeding in the UK context.
Precisely. Nail those 4 down. Maternal ART, mode of delivery, neonatal ART, infant feeding. They are absolutely the cornerstones of prevention.
Got it. Maternal ART, delivery mode, neonatal ART, feeding. Breaking it down like that really helps.
Yeah.
Okay, let's switch gears slightly. Talk a bit about the science, the pathophysiology. What's HIV actually doing inside the body, and how does that link back to the transmission risk we keep talking about?
Right. So the notes explain that HIV's main strategy is to target and destroy those CD4 cells we mentioned.
The immune system generals.
Exactly. They're crucial coordinators of the immune response. As HIV depletes these CD4 cells, the whole immune system gets progressively weaker. And this leaves the person vulnerable to infections and certain types of cancers that a healthy immune system would normally handle easily. We call these opportunistic infections. And crucially, it's this weakening of the immune system and the amount of virus circulating in the mother's body, the viral activity that allows transmission to the baby to happen during pregnancy, birth, or breastfeeding. The notes actually reiterate that point about the high risk without intervention, somewhere between 15% and 45%. Understanding this mechanism and just how high the baseline risk is really drives home why those 4 pillars of prevention are so incredibly effective.
Yeah, it puts that 2% figure into even sharper focus, doesn't it?
Yeah.
Knowing what it could be. Okay, so if someone presents with symptoms during pregnancy that might suggest HIV, what else do doctors need to think about? What about the differential diagnosis section in the notes?
Well, because a lot of the early HIV symptoms are quite non-specific things like feeling flu-like or tired.
Yeah, it could be anything.
Exactly. So doctors need to consider other things too. The notes keep this part pretty brief, but they mention ruling out other reasons for a weakened immune system, other immunodeficiencies.
Okay.
And also considering other viral infections that might cause similar general symptoms. It's really about making sure you're not missing something else and doing a proper workup based on the clinical picture.
Right. Standard diagnostic process. Don't jump to conclusions. Okay, zooming out a bit, epidemiology.
Yeah.
How common is HIV in pregnancy? What do the notes tell us about trends, say, in the UK?
The notes actually point to some positive trends, which is good news. In the UK context, they indicate there's been a decrease in new diagnoses of HIV among pregnant individuals.
Oh, that's great.
Yeah, and this is seen as a direct result of really successful public health strategies like widespread screening during pregnancy and, of course, the effectiveness of RP in preventing transmission. But the notes also add a bit of caution. The prevalence, like how many people are living with it, isn't uniform. It can still vary quite a bit depending on the specific population group or the area you're looking at.
So progress, but work still to do.
Pretty much. It tells us that while things are moving in the right direction, continued awareness, screening, and prevention are still really important.
Definitely encouraging to hear about that decrease, though. A real win for public health. But, as we said, symptoms can be tricky. So, what does the clinical presentation typically look like, according to these notes, if someone does have HIV during pregnancy?
The notes state that generally the symptoms of HIV infection in a pregnant person aren't really different from someone who isn't pregnant.
Right.
So that could include things like an initial flu-like illness soon after infection, maybe fatigue, weight loss, getting infections more often than usual, and then in later stages, those opportunistic infections we talked about earlier.
Right.
However, and this is a really critical point, the notes stress many individuals with HIV are asymptomatic, especially early on.
Meaning no symptoms at all.
Exactly. You might feel completely fine. And that's precisely why just relying on symptoms is not enough. It underlines why routine testing, screening during pregnancy is so absolutely fundamental for diagnosis.
Yeah. That makes total sense why screening is universal then. If people feel fine, you'd completely miss it otherwise.
Yeah.
Okay, so moving on to investigations. How do you diagnose it then, if not by symptoms? And what other tests are key for management according to the notes?
Okay, so the diagnostic process described in the notes usually starts with screening tests. These are often serological tests looking for HIV antibodies in the blood,
Hmm.
or sometimes they use these combination antigen antibody assays, which can potentially pick up the infection slightly earlier.
Okay.
If those initial screening tests come back reactive or positive, then you must do confirmatory testing. That's usually done with HIV nucleic acid tests, sometimes called NATs.
What do they do?
They look directly for the virus's genetic material, like its RNA or DNA. It's a very specific test. This two-step approach screen, then confirm, ensures accuracy and avoids false positives.
Right, makes sense. Screen broadly, confirm specifically. What else?
Well, beyond just getting the diagnosis, the notes highlight other crucial tests needed for monitoring the condition and guiding treatment during pregnancy. Two key ones are the CD4 cell count.
Right, the immune system health check.
Exactly, and the viral load. That measures how much active virus is actually circulating in the blood.
And these are really important.
Absolutely critical. These two numbers are essential for deciding on treatment, checking if the treatment is working, and assessing the risk of transmission. The notes also mention testing for other STIs, which is just standard good practice. And of course, ongoing monitoring of these markers throughout the pregnancy is vital to keep track of that transmission risk to the baby.
Okay, so a clear diagnostic path and then regular monitoring with CD4 and viral load to guide everything. That brings us squarely to management, maybe the most critical bit for revision. How is HIV in pregnancy actually managed based on these notes? What are the key decisions around treatment and delivery?
Right. This is where it all comes together. Management is very much a team effort. It's multidisciplinary. You've got HIV specialists, obstetricians, neonatal or pediatric teams all working together.
Makes sense.
And the number one goal, as we've said, is reducing that transmission risk. So the notes state that standard practice, a public health measure, is that all pregnant women are offered HIV screening.
Because of the asymptomatic point.
Precisely. You have to test to find it. Now, if someone is diagnosed, antiretroviral therapy, RT, is offered to all pregnant individuals found to have HIV,
Regardless of anything else.
regardless of their CD4 count or whether they were on treatment before pregnancy. The key is getting that viral load suppressed as much as possible, as quickly as possible.
Okay, RT for everyone diagnosed. What about delivery? That sounds like a big decision point.
It is, and the notes are quite clear. The mode of delivery decision heavily depends on the mother's viral load, specifically measured around 36 weeks of pregnancy.
Ah, okay, there's a specific time point.
Yes, and there's a key number to remember here. The notes specify that a vaginal delivery is considered a possibility if the maternal viral load is suppressed down to less than 50 copies per milliliter.
Less than 50 copies.
Well, less than 50 copies per ml at 36 weeks. That's a really, really high yield number for you to remember. VL less than 50 at 36 weeks generally means vaginal delivery can be planned.
Okay, VL 50 at 36 weeks, aim for vaginal delivery. What if it's higher?
If the viral load is 50 copies a milliliter or higher at 36 weeks, or sometimes for other unrelated obstetric reasons, then an elective cesarean section is often recommended.
To minimize exposure during birth.
Exactly. It further reduces the baby's contact with maternal blood and fluids. And the notes add a detail here. If a C-section is being done because the viral load is high, the mother is often given an intravenous infusion of one specific ART-T drug, zidovudine, during the procedure itself.
Okay, extra protection during the C-section if the viral load's up. What happens after the baby's born?
Right, then management shifts to the newborn, the neonate. If the mother's viral load was well controlled, so less than 50 copies at 36 weeks, the baby is typically given oral zidovudine, just that one drug, as a preventative measure, usually for about 4 to 6 weeks.
Okay.
The notes imply that the neonatal treatment might be different, perhaps more intensive if the mother's viral load was higher, but that specific detail, zidovudine for 4 to 6 weeks if maternal VL was 50. That's a key takeaway.
Got it. And feeding.
And finally, infant feeding. Again, for the UK context, the notes are very clear. Breastfeeding is not advised. This is purely to prevent any risk of transmission through breast milk.
So formula feeding only.
Formula feeding is the recommendation. So really zero in on that viral load threshold. 50 copiesimal at 36 weeks. It's the trigger for decisions about delivery mode and the duration of that basic neonatal zidovudine treatment.
That 50 copiesimal at 36 weeks really does seem like the magic number, doesn't it? Driving those crucial management choices. It's a perfect example of how lab results directly inform clinical action. So after doing all of the RT, the delivery plan, the neonatal treatment, what's the outlook? What do the notes say about prognosis for mother and baby?
Well, the notes paint a, thankfully, much more positive picture for prognosis now compared to, say, a few decades ago. It all comes down to effective management.
Right.
They really emphasize that with good prenatal care, the mother consistently taking her RT and putting all those preventative measures in place.
Well, pillars.
The 4 pillars, exactly.
Yeah.
The outcomes for both the pregnant person and the child are significantly better. Transmission risk is way down.
That's fantastic.
It is. The notes do add a touch of realism, though. Long-term prognosis can still vary. It depends on things like how well someone responds to treatment over many years, their ongoing access to health care, and whether any other complications pop up. But that immediate outlook related to the pregnancy and preventing transmission, it's been completely transformed.
That's incredible progress to hear about. But even with excellent management, are there still potential bumps in the road? What complications can still be associated with HIV in pregnancy, according to the notes?
Yeah, the notes mention a couple of main areas for potential complications. First, obviously, there's still that risk, however small it now is with good management, of mother-to-child transmission. If RT isn't taken properly or the virus isn't suppressed, that risk naturally goes up.
Okay.
Second, the notes mention that having HIV might slightly increase the risk of certain general pregnancy complications for the mother. Things like preterm birth, the baby having a low birth weight, or potentially other issues affecting the mother's health during the pregnancy.
Right. Other obstetric risks.
Exactly. But again, the notes loop back to say that effective management, keeping the mother healthy and the virus suppressed, is key to minimizing these risks too, and improving the overall outcomes for both of them.
Okay. So let's try and wrap this up. What does this all mean? We've taken these sort of dense revision notes and done a real deep dive into HIV and pregnancy. We've gone systematically through the definition, how it's transmitted, the risks, the science bit, the differentials, the prevalence, how it presents, how you test for it, and crucially, those management strategies aimed right at stopping transmission. We pulled out key things like that huge drop in risk, the 4 pillars of prevention, and that really important viral load number, less than 50 guiding delivery.
Absolutely. And understanding these core principles, especially those interventions that have just revolutionized outcomes and slashed mother-to-child transmission rates, it's just fundamental. Whether you're revising this for an exam or you're going to encounter it in clinical practice, it really hammers home the impact of diagnosis and effective treatment. And maybe here's something to think about, sort of extending beyond the notes. We've talked about the incredible success stories, like in the UK, thanks to these strategies, but maybe consider the ongoing global picture. How do we ensure that every pregnant person with HIV, no matter where they are, gets access to the same level of screening, the same effective RT, the same informed delivery choices, the same care that makes these low transmission rates possible? What are the barriers out there, and how can the progress we've seen in some places help efforts everywhere else?
That's a really important point. Access is key, isn't it? Definitely something critical to ponder. Well, if this deep dive has helped you get a firmer grip on HIV and pregnancy, maybe for your revision, maybe for the wards, and you're looking for more of this kind of high-yield, clinically focused material, then definitely check out passthemsra.com and freemsra.com. They're packed with resources designed just like this to help you nail the key information you need on your learning journey.
Yeah, great resources.
You can find them at passthemsra.com and freemsra.com.